Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is going to be on all things pertussis, or whooping cough. We're going to particularly be diving into outbreaks in the past, how things have changed over the years, the bacteriology and pathophysiology of what pertussis is, what causes it, the incubation period, how you transmit it, the symptoms and clinical features, including the 3 different stages, the severity, why it can be deadly to different people, how to diagnose it, the different ways to treat it, as well as the different preventative steps, including vaccination, post-exposure prophylaxis, and hygiene methods to prevent getting it. This will be hopefully a good kind of basics foundation for understanding pertussis. There's been a ton of press on outbreaks and how cases of pertussis have been much higher lately than they have been in the past decades. This will hopefully give you a better way to understand pertussis. A couple quick shout outs before we dive in. First is we have a Patreon page, both for free membership as well as paid membership, that we update very regularly. So we would love for you to check that out and join our Whiteboard Medicine Patreon community. The other thing is, if you're new to the channel, we are the channel of Whiteboard Medicine. We cover medical news and medical education. We do have a handful of videos we've come out recently on these high-yield kind of infectious disease topics. We covered norovirus in the recent past. We also covered E. coli in the recent past. We'll link those as well as our infectious disease playlist in this video's description to check out. With no further ado, quick 30-second break for introduction. Don't go anywhere. We will be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
All right, thanks for sticking around. Pertussis, also known as whooping cough. This is a disease that has really flogged a lot of the world for many, many decades. This here is data from the CDC. Their data, we appreciate them allowing us to put it on here, and we'll link it in the video description, just to give us an idea of cases and how things have changed over time. So the first year they reported on it was 1922, and there was 107,000 cases of pertussis in the United States alone in 1922. And you can say every year thereafter, there is hundreds of thousands of cases, and it stayed this way for decades, right? 1933. This is 1933. We cut out a lot. This goes to 2011 because a lot of these years, just hundreds of thousands of cases of pertussis. People would get critically ill with it. People would die from it, particularly infants and elderly folks or those with immunocompromised states. It's also very bad for pregnant patients. But as we're going to get into this towards the end, as vaccination came out, better understanding of what it was and how to prevent it came out, better treatment modalities came out, and more awareness in general, cases really dropped. And in the 2000s, you can see that cases were primarily kind of low mid 10,000s, 2011, 2012, 2014, etc., etc. That was up until COVID came. When COVID came, cases plummeted to the low thousands, but more typically, we're kind of this low 10,000s. This is in the USA, as we talked about. We did report on here for y'all, just so you had an idea of kind of the world situation, that the World Health Organization reported 150,000 cases globally in 2018. So there's still, hundreds of thousands of cases worldwide. But in the United States, cases really were in the low 10,000s in the 2000s. COVID, they dropped to the low thousand single digits. In 2024, though, this year, a lot of the headlines out there are that there's been tens of thousands of cases, more than we've seen in recent years. And part of that is because of COVID, right? When there was COVID, people were much better at masking, hand hygiene, not, getting into crowded spaces with people who are sick, staying home when you're sick. There's just a lot more awareness of that. So cases had really plummeted of pertussis, among a bunch of other things: influenza, respiratory syncytial virus, human metapneumovirus, all these other respiratory viruses and bacteria. But we've kind of returned to the pre-COVID era of cases. but even a little bit higher. It's kind of like there's been a rebound effect. 2014, we had almost the same number of cases, but these cases, the 30s to 40,000s, we're not even seeing that frequently before COVID. So cases are up overall, and there is a pretty good outbreak going on currently of pertussis, and we're going to get into a couple reasons possibly as to why as things go on. So pertussis does get in the United States tens of thousands of people sick, in the world hundreds of thousands of people sick, but in 2024 the cases kind of skyrocketed, rebounded heavily after COVID with a huge increase in cases. So what is pertussis? What is it caused by? What's kind of the pathophysiology? How does it make you sick? All that good stuff. Well, it is actually caused by a bacteria. A lot of the kind of respiratory infections we talk about in the winter are caused by viruses. But this is caused by a bacteria, meaning it responds to antibiotics. And that bacteria is called Bordetella pertussis, right? So that's where we get the name pertussis, is this portion of it here, but it's caused by the bacteria Bordetella pertussis. And this bacteria is a gram-negative bacteria. For those of you unaware, this is part of the way we categorize bacteria is something called the gram stain. Gram stain positive versus gram stain negative. This is a microscope picture of pertussis, Bordetella pertussis. We almost forgot how to spell microscope. Good. And you can see it's kind of pink in color, and that's gram negative. When it's purple in color, pretty similar to what we would say this would be, right? This is gram positive when it's purple in color. When it's pink in color like this, it's called gram negative. And that just has to do with the ability for the gram stain to stain the outer bacterial wall of the bacteria. If it does stain, it's purple. If it doesn't, it's pink. So just a way for us to kind of categorize it. It was first discovered in 1906. So been around for over 100 years, probably been around longer than that, but has been discovered for over 100 years. And it was discovered by, I'm sure I'm going to mispronounce these, Bordet and Gangau. And you can see the Bordet portion of this, Bordetella, is where the name came from. So the named after, the person that discovered it. And this person's name is in the way we grow pertussis in the lab, which we'll get into. So that's a bacteriology. How does it make us sick? Well, it produces actually several different toxins. Toxins are molecules that a bacteria or a virus produces that then circulate in the body and make us sick. It's how they kind of create disease. And the first of those toxins is adequately named the pertussis toxin. And this toxin causes dysregulation of the immune system. So it causes our immune system to go a little haywire. It also produces a toxin called adenylyl cyclase toxin. People call this ACT for short. And it does a similar thing, right? These are very complex pathways. We're kind of just using generalities here, but also deregulates the immune system. Another one of the toxins people talk about is called the tracheal toxin. And this toxin actually destroys ciliated cells on the surface of the trachea. So we're going to scroll over here and we'll just draw a trachea, right? The trachea is the windpipe. So here's lung, this is the trachea. Trachea goes up to, out of the body, and eventually it goes to a person's mouth and they breathe in air. But the trachea has a bunch of cilia. These are kind of hair-like projections, and the cilia helps us clear things out of the lungs, right? The cilia kind of moves these particles up towards our vocal cords, and then we cough things out, right? But pertussis, the tracheal toxin, destroys ciliated cells on the surface of the trachea, so you are less able to clear all that gunk out of your lungs, including the infection. And it also produces something called the dermonecrotic toxin, which just helps bacterial survival, so it helps the pertussis bacteria survive. So you have a number of toxins here that dysregulate the immune system, destroy different cells in the lungs that would help you clear the infection and help the bacteria survive. In addition to that, the bacteria itself has a bunch of really interesting ways that it can help infect us. Because pertussis, as we'll get into, is a respiratory infection. It infects both the upper and lower respiratory tract, upper being kind of the nose, trachea, and lower being the alveoli deeper in the lungs. That can cause things like pneumonia. This is our rendering. We actually thought it was pretty good of Bordetella pertussis, the bacteria. This is our drawing of it. And you can see here, this is the bacterial wall, this is the nucleus, and then it has all these things on the outside, and all these things help pertussis cause disease. It has something called the filamentous hemagglutinin, which helps connect to human cells and invade tissue. Right? Same thing with these fimbriae on the outside. Same things with protactin. And also some called LPS or lipopolysaccharide. LPS is something that can cause a huge immune dysregulation and response. It can make people really, really sick. A lot of bacteria have LPS or lipopolysaccharide, but these are all kind of external parts of the Bordetella pertussis bacteria that helps it get into our airways and kind of crawl along and infect different tissues and connect to cells and all those things that help it cause disease in us. So this is the way it gets into the body, stays in the body, and then the toxins are the way it causes disease. These also have some disease-causing abilities too. It's all kind of interconnected, but hopefully that helps understand, because the toxins usually will be inside of the bacteria, and then the bacteria will release the toxins, whereas these are all in the external part of the bacteria that helps it start the infection. All right, incubation period and transmission. So now that we know what the bacteria is, how it causes disease, and that it does cause disease based on the number of outbreaks, well, how is it transmitted person to person? How long does it stay in someone before it causes symptoms? One of the big challenges is the incubation period is usually 5 to 10 days after exposure, but it can be as long as 21 days after exposure, and a number of those days you could be contagious. So this can kind of linger inside you and not cause disease for up to 3 weeks. So you might have been exposed to someone, 2.5 weeks ago, and then all of a sudden you get sick, and you're like, gosh, why am I sick? I don't know I was exposed to anyone. You can also start to spread it before you get symptoms. So it's a really long incubation period. Granted, most times it's 5 to 10 days, but it can be dragged out. This will be relevant for some of the post-exposure prophylaxis. And then it's transmitted like a lot of respiratory infections through droplets, respiratory droplets, sneezing, coughing, breathing droplets close to someone, sneezing or coughing mucus onto a surface. Then I touch the surface, touch my face, or put my fingers in my mouth. That can be a way to get it. Touching my mucous membranes in my eyes or my nose after my hands have been contaminated. So this is pretty classic for a lot of respiratory infections. A lot of respiratory viruses like influenza and respiratory syncytial virus are spread in similar ways, but it's droplet, okay? So it's not like the fecal oral route or those types of things. It's all through respiratory droplets. Very contagious, though. Very contagious. So what symptoms and clinical features can you expect if you were to get pertussis? Well, pertussis has 3 different stages. It has the Catarrhal stage, hopefully we said that right, the paroxysmal stage, and then the convalescent stage. The first stage, the Catarrhal stage, is about 1 to 2 weeks long, okay? And this is when you kind of have the common cold, normal respiratory symptoms. You get a cough, you get congestion, some slight fevers, and in this stage you are highly, highly contagious. This is also a stage where you can start to get really sick, as well as the proximal stage. And the way you can get really sick is you can get pneumonia. It can cause infants to stop breathing, apnea, and it can lead to death. So young infants, elderly folks, comorbid folks, pregnant people are high risk to get very, very sick from pertussis. After the 1 to 2 weeks of the kind of common cold respiratory symptoms, it transitions into what they call the paroxysmal stage. And this is 1 to 6 weeks long, so it can drag out a long time, right? Up to 6 weeks, 42 days. And this is where it gets its namesake of whooping cough, because you get this severe cough, up to 15 episodes today. And the whoop itself is an inspiratory whoop. We debated whether we were going to try this on the microphone or not, and we said we weren't, so I didn't practice it, but maybe we'll give it a go. So you essentially cough so hard you run out of breath. And then you whoop when you breathe inwards because you're so short of breath, you kind of pull in this huge whoop to try to get air after you've coughed so hard. People also get post-tussive emesis, tussis being cough, so you cough so hard you vomit. And again, this can happen 15 episodes per day, so this is even more than that, where you get these huge, incredibly severe coughing episodes, inspiratory whoops, post-coughing vomiting, and you still remain contagious, a little less contagious than this initial Catarrhal stage, but you still remain contagious. This then transitions into the convalescent stage, and this is when things finally start to calm down. You get slow improvement over time of that cough. You're no longer contagious, but it can take months. The cough is really the gift that keeps on giving here, and it can last for months, but over time it kind of gets less and less and less and less. You stop whooping, you stop having post-tussive emesis, and you finally do heal. But pertussis, Unlike some respiratory illnesses, really can stick around for a long time, can have a huge burden on someone's quality of life. It can make you really sick. It can also lead to hospitalizations, it can lead to death in certain populations. This is the real deal. This is a serious thing. And as you saw, we do have much more cases this year than we've had in recent years in the past. So if you have the symptoms, how do you diagnose it? And even more importantly, how do you treat it? Well, there's three different ways to diagnose pertussis. One is a bacterial culture. This is when you get a specimen from someone's nose or oropharynx and you actually grow the bacteria on special medium. And they need, oh, do these look familiar? Bordet Gangau blood agar, right? These were the individuals that discovered it in 1906, because you can't just grow it in normal bacterial growth media. You need special media to grow pertussis. This is the most dependable way to diagnose it. People say it has 100% sensitivity or it is positive 100% of the time. There aren't any false negatives. But it also takes time. It takes days to grow out a bacteria. It's not universally present. A much more common, faster, and also very sensitive modality, and one we use for a lot of different infections, is PCR, polymerase chain reaction, PCR, polymerase chain reaction. And this is when you do a nasopharyngeal swab, so a swab from the back of the nose, kind of where it meets the pharynx. You can do an oral pharyngeal swab as well, and you run it in a PCR machine where it looks for fragments of the bacteria, and then it replicates those fragments and pops positive. This is a much faster result. This takes hours rather than days, right? This one takes days. And it has a really good sensitivity too. It's not quite 100%, it's less than 100% sensitive. There will be some false negatives, but it's got a really good sensitivity. Last is serology. And serology is where you actually draw blood from a patient and look for antibodies against the pertussis bacteria to suggest that you've had it. It can be performed later in the disease course, and it really needs to be performed later in the disease course. But since you can sometimes have a cough for months, at times this is helpful because someone can draw your blood and see if maybe you did have pertussis recently and that's the cause of your chronic cough. In addition to that, as we'll get into, sometimes you do prophylaxis for 21 days after symptom onset for someone, and sometimes the swabs at 21 days won't be positive anymore, so sometimes you have to do serology to see if they did have pertussis. But the most common, far and away, is the PCR test. This is what we use at the hospital when we're diagnosing pertussis, is a swab with the PCR test. All right, treatment. How do you treat pertussis? Well, treatment for pertussis is antibiotics, right? Because we said this is a bacteria. Viruses like influenza, respiratory syncytial virus, metapneumovirus, none of those respond to antibiotics. They're not bacteria. But pertussis is a bacteria, and as such, antibiotics work to treat pertussis. The key, though, is earlier in the disease course, the better. Because we said this can stick around, right? If we scroll back up, we said you can get the convalescent stage for months. So when do you still treat pertussis? When is treatment effective still? And you really want to try to treat it less than 2 weeks from symptom onset. So before you start getting those coughing, paroxysmas, and inspiratory whoops and things, that is when treatment is most effective, less than 2 weeks from onset. Now the CDC does put some more guidance out there, right? They say that reasonable guideline to treat is people 1 year of age or older. Treat it within 3 weeks of coughing onset. All right, so most effective less than 2 weeks, but treat up to 3 weeks of when your symptoms start. Infants younger than 1 year of age, they extend this to 6 weeks from coughing onset, right, or 42 days. And the reason is because young infants can get really sick from pertussis, so they extend it longer. Pregnant women, 6 weeks of cough onset as well, because pertussis is really bad for mom and for unborn baby. Okay, so 21 days for most people, 42 days for people who are higher risk. And what you treat it with is traditionally an antibiotic called a macrolide. Azithromycin is a macrolide. It's the most common one. This is what brand name would suggest is a quote-unquote Z-pack. Treatment is for 5 days. You can use an antibiotic called Bactrim or trimethylprin sulfa. Oh boy, we're going to get fired from our job. We forgot the generic name of Bactrim. And it is second line if you have an allergy to a macrolide. But azithromycin and macrolide is the first line treatment. This is classically known as a Z-pack. Trimethylprin sulfamethoxazole is Bactrim. Okay, so that is treatment of pertussis. But in a perfect world, we would not even ever get pertussis, right? So how do you prevent it? The biggest thing here is vaccination. And we certainly acknowledge that everybody has different opinions on vaccines, and we respect all those opinions. So we're just going to share some data. This is reported from NNDSS, pertussis cases from 1922 to 2022, overlaid with different pertussis vaccine rollouts. So remember how there was just kind of like 100,000 to 300,000 cases every year for decades. And then they came out with the DTP, right? This is diphtheria, is the D. T is tetanus, and P is pertussis. This is a vaccine. And you can see that after that vaccine rolled out, you had this tremendous decrease in cases to really low levels for many, many years. They then came out with a different formulation of this vaccine called DTaP, right? And then another formulation called Tdap. When there was a little bit of spike, it went back down. And the vaccine rollout that is the traditional schedule would be that you get DTaP when you're 2 months old, again when you're 4 months old, 6 months old, 15 to 18 months old, and 4 to 6 years old. And then you transition to Tdap. And Tdap you get when you're 11 to 12 years old, and actually every 10 years thereafter for a booster. And this is what has caused pertussis cases to stay super, super low. Interestingly, when we look at the vaccine, there are some numbers that can be interesting to think about, and that is how effective the vaccine is over time. So the efficacy of the pertussis component for children who get all 5 doses, right? We said 2 months, 4 months, 6 months, 15 to 18 months, and 4 to 6 years old. 98% of children will be fully protected within a year following the last dose of the vaccine, right? So the last dose is 4 to 6 years old. But if you put that out to 5 years after the last dose, it goes down only 71% because our immune protection from a vaccine wanes over time, right? Our body has a lot of different immune functions. It's protecting us against a lot of different stuff. So years and years and years after you got a vaccine, that part of your immune memory starts to wane. It starts to fade. Your body's like, I got a bazillion other things I'm doing that seem much more active than this. So I'm going to have less protection against that vaccine I got a decade ago. And it wanes over time. So that's why they came out with Tdap, right? Because Tdap then is what you get after you're a kid. And you get full protection. First year after vaccination, 73% of patients get full protection. That, though, wanes to 34% 4 years after vaccination. And this is why cases can go up if you are years after you get your vaccination. Because 4 years after you got your last Tdap, you only have about 33%, only have about a third efficacy or protection. So as you age, it wanes more and more, which is why they recommend boosters of this to then give you more protection, because you get a lot more protection the first year after vaccination than you do down the road. All right, what other ways can you prevent pertussis? Well, what if you have an exposure, right? You get exposed to someone who has pertussis. In the hospital, this is something that happens, right? If you're within 21 days, so let's say someone comes in and they come in for a cough that they have had for 20 days, or let's say your family member has had a cough for 20 days, and they get diagnosed with pertussis. There's a recommendation that all household contacts of that person get a prophylaxis dose of antibiotics, that macrolide, that is azithromycin. Anyone in a high-risk group who has had contact with that person, infants, people with comorbid conditions, people immunocompromised, or those with contact with high-risk groups, so those in contact with any of these people. So let's say that my significant other got pertussis, they've had a cough for 20 days, I live in the same house as them, it'd be recommended that I take a macrolide antibiotic to prevent me from getting pertussis. Now let's say that I am immunocompromised and my friend got diagnosed with pertussis 19 days ago, but I don't live with them. I'm still a high-risk group who had exposure to that person, so it's recommended that I get an antibiotic for prophylaxis, even if I have no symptoms. Or let's say that I have an infant and my friend has pertussis. It'd be recommended that I get a macrolide antibiotic as prophylaxis to prevent me from getting it because I live with an infant who is a high-risk group. But if this was 30 days So let's say that my significant other has had a cough for 35 days. They get diagnosed with pertussis. It's no longer recommended that I get prophylaxis because they're more than 21 days from their cough. And the reason is because of the incubation period. If I scroll all the way up, the incubation period, we said, is as long as 21 days. So if I had an exposure to someone more than 21 days ago and I don't have symptoms, it means that I most likely did not get pertussis because I should have been showing symptoms by then, right? That's why it's less than 21 days is when you do your post-exposure prophylaxis. And then last but not least, hygiene. This is normal stuff. We didn't kind of put a whole big thing here. Wash your hands, clean surfaces, wear masks if you believe in that kind of thing, although there's mixed literature. Avoid touching your face, right? This is a droplet contagious disease. So anyone coughing on you, sneezing on you, breathing heavily on you who has pertussis can give it to you. Anyone who sneezes on your doorknob, then you touch your doorknob and put your hands in your mouth can give it to you. Anyone who holds the same railing as you and then you rub your eye can give it to you. So these are normal kind of respiratory infection precautions, good just kind of universal precautions in general. All right, hopefully that was helpful. Hopefully you learned something. Hopefully it maybe was interesting too. Let us know what thoughts, comments, questions you have down below. Subscribe, hit the bell button, check out our Patreon page, all that good stuff. We appreciate you all. Stay well, keep learning, and we will see you all next time.